In this presentation, we're going to talk about the chronic inflammation that we see in burn injuries. So you have to remember the function of the skin because it's that important barrier that's made up of the dermis and the epidermis that are separated by that all-important basement membrane. The skin protects the internal structures from infectious, harmful agents and mechanical damage, prevents dehydration, it regulates our body temperature, and it produces vitamin D. So when we have a burn from thermal injury, electrical injury, whatever, it can really cause some serious problems to our body's ability to maintain hydration and regulate body temperature and many other issues. Thermal injuries, the severity of the burn, and this is like heat, right? The severity of the burn is going to be related to the rate of the temperature, and the higher the temperature, the worse, as well as how long the exposure was. So the longer, the worse. So high temperature, long exposure, bad. Thermal injuries, temperatures above 113 degrees Fahrenheit cause proteins to break down or denature, and that results in irreversible cell damage. As we talked about in Module 1, extreme cold can also result in a type of burn that causes cellular death. Chemical injuries, the extent of the damage from chemical injury, again, is going to depend on the chemical itself and how toxic it is, the location of the exposure, like whether it gets into the eyes, the respiratory tract, the GI tract, and also how long you're exposed to it. Electrical injuries are going to follow the path of least resistance along the body, along tissues, fluid, blood vessels, and nerves. So that's how it's going to travel. So when you have a serious electrical trauma, it's going to result from the electrical current, not just where you were exposed to it, but it actually passing through vital organs, nerves, and blood vessels. Electrical currents can disrupt cardiac conduction and even cause death. All burns involve an injury that triggers an acute inflammatory response. The extent and nature of the inflammation is going to depend on the surface area, so how much of the body is covered by this burn, as well as how deep the burn injury is. So the thickness of the burn is going to matter. There's first, second, and third degree. First degree burns are known as superficial partial thickness burns. Here there's no cellular necrosis or scarring. The extracellular matrix remains intact, so this is going to allow for uneventful healing, and we're not even going to see a blister. Examples of this would be mild sunburn that triggers vasodilation of the dermal blood vessels, increases the capillary permeability, which is what causes the redness that you see in the sunburn, and also the pain and the swelling from our friends bradykinin and prostaglandins that we know get triggered during that inflammatory process to help dilate the blood vessels and make them more permeable. But this type of wound, burn wound, is going to heal pretty quickly. It's going to heal by epithelialization without scarring. So you're going to have the skin just kind of fluffing off the top layer of the damaged skin. Second degree are known as deep partial thickness burns. In this type of burn, there is actually damage to the epidermal skin layers that penetrates down to some of the dermal layer. During this type of burn, the epidermal and the dermal layers separate, and fluid accumulates there because, again, it's an inflammatory process because there was an injury, right? And we know that happens every single time. And as a result of that fluid getting between those layers, we end up with a blister. So second degree, you're going to have a blister. We also see the skin losing its ability to function as a barrier. So our friends prostaglandin and bradykinin come back into the area and cause pain and redness. If necrosis occurs in that upper epidermal layer, cell layers, but the basal membrane cell layer remains intact, we won't end up developing a scar. But more often than not, necrosis happens in both the epidermal and the upper dermal layer. And so then we see the collagen filling in the gaps that gets removed and then gets removed after damaged tissues are fixed up. Then we end up with too much collagen buildup, and that causes tissue fibrosis, which causes scarring at the burn site. This type of burn, second degree burn, takes longer to heal, so 2 to 4 weeks. Third degree burn. These are called full thickness burns. These burns damage the epidermis and the dermis and can penetrate the subcutaneous layers. They destroy blood vessels, and that's usually happening because the heat actually cauterizes the blood vessel or seals it. Healing of the full thickness burn is going to be challenged based on extensive loss of elastin, needing to replace skin cells with collagen, and the fact that they're more prone to invasion by microorganisms. The destruction of the extracellular matrix happens in this kind of wound, and that makes regeneration of the epithelial cells very, very difficult. So they do tend to have scarring, and it tends to be extensive. They're also going to lose elasticity at that area of scarring, so they end up with what's called contractures. So if you were to be burned over your hand, the scarring would be so bad that you wouldn't be able to move your hand the way that you should. So when we lose our barrier, our skin function, what happens? When we have a severe burn injury, which is a full thickness burn that covers more than 20% of the adult body surface area, it's going to cause some potential complications. It can cause shifts in body fluid that can cause impaired blood circulation, edema, and dehydration, and it can be extensive. Microorganisms can actually get in there and cause infection. There's a big risk for that. There is an overwhelming demand on the body for metabolism that is going to increase the risk for malnutrition. And there's going to be problems with temperature regulation because we need our skin to, get rid of fluid or hold fluid in, and it won't be able to do that when it's got this bad of a burn. So there's also a huge, 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 cannot emphasize enough, huge risk of shock in patients that have this type of a severe burn injury. Shock is nothing more than widespread inflammation everywhere in the body. And when we have this widespread inflammation everywhere in the body, all of the blood vessels dilate, all of the blood vessels have that increased permeability, fluid and protein move out of the blood vessels, meaning there's not enough water and fluid and blood in the blood vessels to perfuse our vital organs. So they end up with dropped blood pressure. Their heart's going to try desperately to compensate. So many types of shock, you're going to see the heart trying to beat really fast to try to get more blood flow out, but it's not going to work if we don't resolve the underlying problem, and we won't get enough blood and nutrients and oxygen to our kidneys, to the muscles of our heart, to our liver, to our intestines, to all of our vital organs, and they will fail, and there's a huge risk of death. So when we have this widespread inflammation, this shock following a severe burn, again, this is what's happening. You're having widespread inflammation with massive capillary permeability everywhere. This causes direct damage to the blood vessels, not only at the site of the burn, but everywhere. And we end up with tissue edema at the site. If they have this full thickness burn, they're going to end up with losing a lot of water. And when that full thickness burn covers 70% of the body, the extensive fluid shift of all of the protein and the fluid out of those permeated blood vessels cause all the tissues to swell, which causes that severe hypovolemia that I talked about. Hypovolemia literally means hypo, low, volume, vol, emia in the blood, not enough volume in the blood vessels. That's never going to be enough to perfuse our organs. It's going to restrict the oxygen in the blood that is flowing everywhere. And so we have this oxygenated blood flow that's restricted, and that causes necrosis. Remember that from module 1. And then that hypoxic tissue becomes even worse, even more hypoxic. The heat also converts the shape of the red blood cells so that the flow of blood, similar to what happens in sickle cell anemia, but not exactly. But it's going to do the same thing and kind of make them clump so that the flow of blood does not go the way that it should. The blood becomes very thick and viscous, and they tend to form more clots, particularly at the site of the burn. They have poor perfusion, which results in damage to the vital organs, like I mentioned. Why? Because our vital organs need a constant supply of oxygen and nutrients in order to survive. In partial thickness burns, we have that capillary permeability that tends to get restored in about 1 to 2 days. And when that happens, that interstitial fluid shift decreases. So we start to see the edema going away. But if that injury is severe enough, that risk for shock increases. So the worse the burn injury, the worse the risk for shock. So the loss of that skin function that barrier is going to allow microorganisms to get in. Burns that cover large surface areas really pose a big risk for this. And when we have bacteria getting into the blood, there's a big risk for, well, bacteria in the blood is called bacteremia, and that can lead to sepsis, which can in turn trigger septic shock. So full thickness burns cause that dead tissue and that exudate to convert into that eschar, that thick scab, and that eschar actually has to be surgically removed in order to prevent extensive microorganism growth. And the body is going to use up all of the protein and all of the oxygen trying to repair that major injury. So if we don't give that person more oxygen and more protein and more nutrients, they're not going to get what their body needs to heal. So I really wanted to break this down for you based on what you see in these types of burn injuries. So superficial, that first degree, you're going to see redness, warmth, pain, swelling, loss of function of the infected area, but it's just that top surface, so no blister. The deep partial thickness burns are second degree. They're going to have the redness, the warmth, the pain, the edema. They're going to have that serous clear fluid that seeps out of the tissue because it's formed between the two layers. So they are going to have blistering, but they're not going to have eschar or that scab formation. Full thickness, third degree burns, here they can actually end up destroying nerve endings, sweat glands, hair follicles, and the destruction of the nerve endings actually inhibits pain response. This is not a good thing. That burn has actually penetrated all of the skin layers. Now, what's weird is they're not going to be pain-free. There's just going to be areas where the nerves were killed, and so that area has no pain, but the surrounding areas are going to be screaming in pain. They are going to have redness, they're going to have edema, exudate, and they're going to have formed that eschar, that scab. We diagnose this based on the depth of the burn as well as the surface area, and that's where your rule of nines comes in. We do it a bit differently for kids under the age of 5. Here, the infant's head and neck are going to make up 18% of their total body surface area, and each lower extremity counts for 14%. But here you see the rule of nines for adults. So like the face is 4.5 in the front or the back, so if the whole head was done, that would be 9. The arms 4.5, the chest 18, the groin area 1. And we estimate this rule of nines, plus we determine how thick or how deep the wound is, the burn is, to be able to determine how bad this injury is. And that badness of the injury, the severity, is going to dictate how we treat it. There's also this American Burn Association burn severity grading scale, which talks about the amount of total body surface area and how we treat it. So minor, moderate, or major. Minor is less than 10% total body surface area, moderate 10 to 20, and major is more than 20%. All of your full thickness wounds, the third degree, are going to be considered major. So anybody with a third degree wound has to be admitted to a specialized burn center. For a moderate wound, burn injury, they're going to be admitted to the hospital and probably need some special burn center treatment. The minor ones, we just treat them at home. So to treat minor or moderate burns, we have to first get rid of the source of the injury, especially if it's a chemical. So you wash that off really very quickly with lots and lots of water. A minor burn, you want to clean it with tepid, which means cool but not cold, or even sterile water. The wound sometimes gets covered with an antimicrobial ointment and dressed using a very fine mesh gauze. And we change that dressing every 1 to 2 days because we want to inspect it and make sure there's no infection growing. And these frequent dressing changes are really important. And many times they can actually aid in debridement. So any pus will have formed into that mesh thing and we pull it off and then clean it and then add more stuff on there. And make sure you medicate these people before you do that because this is a very painful procedure. Moderate and major burns, these ones, any burn larger than the palm of the hand or anything that involves the face, the hands, the feet, or the genital area really requires that they get admitted to the burn unit center. Here the treatment focuses on their airway, their breathing, and their circulation because again they're prone to shock. So we want to make sure they're getting fluids and all this stuff and preventing them from going into shock as much as we can. And they're going to be getting pain relievers, antibiotics, and they're placed in protective isolation to keep them from getting any kind of microorganism. And lastly, the major and moderate burns, they're cleansed with sterile saline. We have to wear powder-free gloves to do it because powder irritates the burns. We actually have to debride them to remove blisters or necrotic tissues and cover the wound with sterile dressings to protect infection. We can actually use hydrotherapy, which is where we soak them in a tub or a shower once or twice a day, and that is done to clean the wound by removing dead and tissue and exudate. We might need to do surgery to cut out or excise the bad area and graft a full thickness wound. Grafting involves using a different part of the body and kind of harvesting tissue. A lot of times we take it from the butt cheek and then put it over the exposed area. And this transplanted epithelial tissue starts to help with that process of healing so the cellular regeneration can occur. They're probably going to have scarring pretty severely, so they may need some psychosocial support.